welcome to our yet again highlights of 2024 of the Comprehensive Cancer Center in Zurich. Warmly welcome everyone being here on site and everyone being online. Of course, it's appreciated being here and participating in the event, and in particular to the discussion at the very end. Thanks to the pharmaceutical companies, to all companies supporting us, very importantly, and we hope we're going to have a good exchange between departments and between all the people here in our room. Andreas Wicki is going to give an overview of medical oncology, practice-changing trials 2024. I hope some of them are going to be practice-changing indeed, and some will be more intensely discussed to kind of bring us closer together. And in the next week, Stefan will kind of update us on medical oncology. So looking forward to an exciting evening. Thank you.
Okay, Matthias, thanks a lot. And you've seen our thanks to our sponsors already. So actually the list of sponsors is changing so quickly. We said we'll not put it on the regular slides, but in a separate file, which is why I now have to switch from one file to the other. Okay, so I was asked to give yet again a brief summary on the highlights on the year 2024. So you will find out when you look at the list, it's 85 slides, okay? We have 75 minutes, which gives me a little bit less than 1 minute per slide. And the fascinating thing is, you know, we're just going to look into things which are either practice changing in the sense of let's do it, or practice changing in the sense of don't do this ever again in your life, okay, if you don't want to go to jail. And then there's very few topics where you can have different opinions on. So let's get started. We start with screening and prophylaxis, and you see it's just 4 abstracts I'm going to present. We're going to see more abstracts then on adjuvant therapy and on the classical oncological palliative therapy. Just for information, I put, you know, in little green what I believe is something which should be done. There's no connect to approval or reimbursement or anything whatsoever. So it's just my very personal feeling. It's something which should be offered to our patients. Then there is some red stuff, which is the don't do it ever again stuff. And then there's the black one, which is, you know, you may have different opinions and it may necessitate a discussion with individual patients, whether you want to go down this road, yes or no. So the first article I want to commend, published last year, is diclofenac, so Voltaren, in the prevention of capecitabine-associated hand-foot syndrome. And I think it's a very interesting trial because using diclofenac for the hands or feet of your patient gives you quite impressive results, basically. So we look at the rate of hand-foot syndrome, grade 2 or 3, in the diclofenac and in the placebo group. And I think it's very obvious there's a huge difference. So it's not the only intervention. There are other interventions for hand-foot syndrome as well, but it's a very effective intervention. It's a very simple intervention, and it does not cost a lot. So basically, I think that's a very good thing to give this also in a preventive way if you give higher doses of capecitabine to your patients. Then ECLIPSE trial. You know, we can measure ctDNA in the bloodstream of patients. And the question is, why don't we use ctDNA to predict occurrence of cancer, actually? And in this trial, they have looked at patients undergoing regular standard colonoscopy, and at the same time, they took a little blood sample and looked at whether they could find tumor-specific ctDNA. And the result, you know, on the right-hand side of this graph, I summarized this. Sensitivity for a full-blown cancer was 83%. Specificity was 90%. But the sensitivity for precancerous lesions, which is what you are looking for when you do an endoscopy, was just 13%. So no way to use ctDNA for screening of tumors, at least colorectal cancer, if we don't get up the sensitivity very significant. So it's something which is not ready for everyday use. Then I'm happy that Anja is also here. In prostate cancer screening, the question was in this trial whether when you have an elevated PSA of more than 3, you should do systematic biopsy of the prostate or an MRI and then just do the biopsies if you do see something in the MRI. And then you biopsy exactly those points where you do see alterations, something like a tumor in MRI imaging. There's 2 graphs. The first one I want to show is the incidence of what they call significant cancers, so cancers, prostate cancers, we assume will lead to clinical actionable and in a way kind of dangerous cancer quad vitam. And you see the difference between the blue group, which is systematic biopsy, and the group with MRI targeted biopsy is very small. So basically you lose 8, 9, 10 patients where you do find an invasive and aggressive cancer out of this population of 6,500 patients. On the other hand, what do you gain? You look at those tumors which are classified as insignificant cancers, so those prostate cancers where we believe even if you do follow up for many years, nothing will happen. You know, the patient is going to be sound and alive anyway without any intervention by the medical doctor. And you see there's also a difference between the 2 curves. It's larger than the difference you have seen before. It's perhaps a difference of 40 or 50 or 60 patients. So basically, you know, when you do a very rough estimate and you discuss this with your patients, the rate of kind of false cancer, insignificant cancers is 10, and the rate the ones you don't find because you don't do the systemic biopsy, while at the same time the rate of those cancers you would have found that are significant is 1. So that's basically the discussion you need to have with your patient when you decide whether you want to go for an MRI imaging in patients with an elevated prostate cancer. It's an interesting strategy. I think there's not right or wrong. I mean, in the end, it's about risks, and you need to have a discussion with your patient. And then finally, the last thing in prevention, which is prenatal cell-free DNA. So if you have got patients who have unusual or non-reportable result, pregnant patients with ctDNA, then this means you need to watch out for cancer. So the rate of occult cancers in this population is close to 50%. So these patients need to be referred and they need imaging. Let's move on. Adjuvant, neoadjuvant, perioperative. So we start with the GI system on the proximal end and we move down to the distal end. Esophageal and GI junction adenocarcinoma, you know that's an older trial, MAGIC versus CROSS, so the old stomach cancer classical approach in the curative setting, MAGIC, versus CROSS, what we do in esophageal cancer, including esophageal adenocarcinoma. And you see there's no difference whatsoever, okay? So that's step 1. Step 2 is ESOPEC, the trial we have seen last year, which is looking at FLOT triple chemotherapy in those patients with adenocarcinoma, irrespective in the end, you know, whether it's gastric, where it is already a standard, or whether it is esophageal, where it is not a standard yet. And when you look at the esophageal cancers, the adenocarcinomas of the esophagus, you do get quite a nice overall survival benefit when you use the FLOT approach. So basically this means a new standard is for those patients, if they have got adenocarcinoma of the esophagus, to use FLOT instead of CROSS. Another trial has looked into the utility of radiotherapy, so adding radiotherapy to a somewhat older scheme, ECF, ECX, which is in a way MAGIC, which I have shown beforehand. So what's the use of adding radiotherapy in the MAGIC patients? And this is Top Gear, and Top Gear results have been presented last year as well. and you see there's no difference whatsoever. So basically, if you take this together, FLOT is the standard for the curative setting in gastric cancer and also in adenocarcinomas of the esophagus. The next question is whether we should add PD-1 antibodies. So should we add checkpoint inhibitor therapy? And the first phase 3 trial out of 3 of those trials, which has been presented last year, is Keynote 585. And this trial has looked into adding checkpoint inhibitors in a completely unselected population of patients with gastric cancer. And you see, again, there's no difference. So adding checkpoint inhibitors in the curative setting for unselected population of gastric cancer patients is a no-go. So that's one of the red stuff, you know, that don't do it ever again in your life. There's one trial still running, which is Dante, and Dante is a trial which was also activated by SAKK. And in Dante, we do have selection for patients, for example, microsatellite instability, PD-L1 positivity. So we will have results in the future on whether some specific subgroups of patients would benefit from checkpoint inhibition in the curative setting in gastric cancer. But again, not for the overall population. Good. Next one is Galaxy. This is a trial which you know, offers some new evidence every year. It's an interesting Japanese trial on looking at serial ctDNA sampling. So basically, they take ctDNA samples, they send patients into surgery, they look in a window, you see the MRD window of 2 to 10 weeks, whether there is still ctDNA positivity. And then they go into surveillance, looking at every few months a new ctDNA assessment. So the first thing you see, DFS, disease-free survival, is a hazard ratio of 12 for positive versus negative ctDNA in this window after surgery. So basically, if ctDNA is gone after surgery, you have good chances of cure, and if ctDNA is still there, you have poor chances of cure. If you look at overall survival, it's very similar. Overall survival hazard ratio of 9.7, so almost 10, which is a very impressive hazard ratio for oncology patients. On the right-hand side, you see the same for surveillance. It's very similar in the end. We're not going to look into all those numbers. That's too much. But basically, if you do find ctDNA positivity later on, you again have a very poor prognosis and a high chance of relapse. Now, the interesting thing is when you look at the different kind of pathways patients can take. So you have those with MRD, molecular residual disease negative ones, and you have the molecular residual disease positive ones. And you see the negative ones tend to stay negative, the positive ones tend to stay positive, but there are some patients moving from MRD negativity into ctDNA positivity, which is kind of a relapse. But at the same time, and that's perhaps even more interesting, we have MRD positive ones, the little green line, moving to ctDNA negative ones, which means a few patients are cured even if they are ctDNA positive right after surgery. So perhaps clearance takes more time and the immune system is going to do something later on in time. So I think that's very interesting. What it means for single patients is still difficult to tell because in the end it's very heterogeneous what happens, and we do not have further marker telling us into which directions the patients are going to move. Next trial is NICHE 2. And this kind of plot at ESMO has been termed Chalabi plot, which is the main author of this graph. And she has investigated a series of mismatch repair deficient gastrointestinal cancers, and all the mismatch repair gastrointestinal cancers, when you give checkpoint inhibition, they look like this. So that's why this is now called the Chalabi plot. Anyway, so it's not an official name, okay? So in this case, they have used neoadjuvant checkpoint inhibition, ipi/nivo, in patients with mismatch repair deficient colorectal cancer, and you see very nice response rates. What this means for clinical procedures, do we at some point in the future perhaps not do surgery on colon cancers anymore? Is not clear yet, but it may be that for those cancers who are mismatch repair deficient, we may even skip surgery at some distant point in the future. It's not something we're going to see in the next 2 or 3 years happening. Then we have finally the long-time results of PODISH 23. For rectal cancer in oncology, it's been a very hard time for many, many years because we have never seen a trial with OS benefit, and actually that's the first one. So it's again a very important moment for rectal cancer oncology. We see after 7 years OS benefit if you use modified FOLFIRINOX or FOLFOXIRI on these patients with rectal cancer. The difference in 7-year overall survival is around 5%. So it's really the first time we see this difference. We've seen other differences like disease-free survival and this kind of stuff in other trials as well, but it's the first one with a clear overall survival benefit. And I'm not sure whether Ralf is here, but this is something which Ralf and his team are doing regularly in our patients. Then we continue with more adjuvant stuff. Now it's imatinib. We started for gastrointestinal stromal tumors with giving imatinib for 1 year. And then we had a trial with giving imatinib for 3 years. And now, obviously, the brilliant idea after giving it for 3 years was, why don't we give it for 6 years? And these are the results you see in this trial. It's only for the higher risk population. So the NCCN risk factors identify a population with a risk of relapse of 35% and more. And if in this population you give 6 years instead of 3 years of imatinib, you do see quite a difference in disease-free survival. However, when you look at the left-hand side at the OS curve, overall survival, there's no difference whatsoever in overall survival, which means probably many of those relapses are in the end localized or locally treatable relapses. And that's why we don't see a difference in the overall survival. So I think it's not necessarily a standard to give 6 years of imatinib, since we do not see an OS benefit. For individual patients, it may be an option if it is very important. They don't have to undergo a new oncological therapy in the next few years. Okay, that's also a nice plot and a nice hazard ratio, 0.16. So that's also pretty rare to see a hazard ratio of 0.16. It's PFS, progression-free survival. It's for osimertinib after chemoradiotherapy in stage 3. So basically, it's giving osimertinib for more or less ever in those patients you have treated with chemoradiotherapy and with an EGFR, an activating EGFR mutation. We don't have OS data yet, so we don't know what overall survival does, but it's a very, very impressive PFS curve. And as always, the question is, do you wait until you do see OS data in this situation, or do you act already on PFS? It's a difficult discussion. For me personally, and for my patients, I believe in this situation where the difference is as large as you can see it here, I would give this drug in these patients, because the risk of doing something wrong if you do it the other way around is probably bigger than the risk you incur with giving osimertinib based on PFS. So I think this is something which should be done in clinical standard. Then alectinib, more or less the same. So we look at all rearranged patients, the adjuvant situation with adjuvant therapy with alectinib. And again, disease-free survival hazard ratio is 0.24. So it's not as impressive as it is for osimertinib, but it's still quite a difference. Again, we're going to see OS data perhaps in a few years. The problem is, and we go a little bit deeper into this later on. There's also the lorlatinib data for the palliative situation, and we see very, very long PFS in these patients with ALK translocation. So this means it will take ages until we're going to see OS data, which also means we need to decide based on the information which is available now already, and this is disease-free survival and nothing else for the time being. Then we move to adjuvant therapies in non-small cell lung cancer. And those patients where there's no driver mutation, we have seen OS data, the interim analysis 2 for Keynote 671, and the hazard ratio was 0.72. And this is actually the first trial with perioperative checkpoint inhibitors in NSCLC adenocarcinoma showing OS benefit. And I guess that's also a standard today. We do have data for perioperative nivolumab, very similar setting, checkmate 77T. We have not seen overall survival data yet for this trial. What we have is event-free survival, and the hazard ratio for event-free survival is 0.58. So probably it's exactly the same benefit we see for pembrolizumab. And nivolumab has gotten approval for the neoadjuvant therapy so far based on another trial, but I think that's also an option for our patients with non-small cell lung cancer. Then a very old story, adjuvant dabrafenib and trametinib, but now we have got the 10-year overall survival data. So it's quite some follow-up. Hazard ratio for overall survival is 0.8. It's not significant after all this time, but obviously, you know, what we never should forget is that OS curves at some time in the not so distant future will converge anyway. So when you look at 10 years OS, then at some point, you know, when you do have patients of a certain age as well, will reflect also competing mortality, obviously, and not just the mortality due to the primary cancer. So basically, I think this just confirms it's a good adjuvant therapy, and basically it still looks quite attractive compared to adjuvant immunotherapy in melanoma. However, it's probably not, you know, in a way not the standard anymore, because we have neoadjuvant therapies, and we get to this in a few slides. Now, that's a very interesting trial. It's not really practice changing yet because it's a phase 2 trial, but this is an individualized vaccine. So they have produced this very specific vaccine for individual patients and looked at relapse-free survival in melanoma. These are the results. So you see, you can give the mRNA vaccine plus pembrolizumab or pembrolizumab on its own, and you see this very nice hazard ratio difference in relapse-free survival. So I think that's quite impressive. It's not a pivotal trial. We're going to see more data on this. But basically, you know, when you look at your patients, using these generic antigens to vaccine has always proven to be difficult, but using the very personalized ones, so when you can look at, for example, scrambled antigens because there was a frame shift mutation or something like that, and build this into mRNA within 6 weeks or something, then I think this is a very attractive way to move forward. The interesting thing is, you know, you can look at this population now in the TMB high and the TMB low. So what does the tumor mutational burden play a role in this population? You see for the tumor mutational burden, if it is high, the difference seems to be rather small. If you look at those where the TMB is not high, the curves separate more significantly. So very preliminary data, but very fascinating that we are able to produce personalized vaccines, use them in the adjuvant setting, and may also have some biomarkers helping us to determine, you know, who does benefit from this kind of approach and who doesn't. So I talked beforehand about the neoadjuvant therapy, and we've seen 2024 also neoadjuvant therapies for melanoma, the famous NADINA trial. And NADINA looked at giving 2 cycles of ipilimumab and nivolumab in patients with melanoma. They then underwent surgery. And if there was a major pathological complete response, then there was no further treatment. So just these cycles of ipi-nivo before surgery. And if there was more than 10% tumor cells, they went into further adjuvant therapy, be it checkpoint inhibition or a combination of TKIs. And this was randomized to surgery followed by adjuvant immunotherapy. So very pragmatic, informative design. We have not seen OS data, but we've seen the event-free survival data, hazard ratio 0.32, which is again quite impressive. Doing neoadjuvant immunotherapy using ipilimumab and nivolumab has become a standard at USZ, so in the dermatology department and the melanoma board. This is how we usually decide about the standard therapy partners. You're there often, so that's what we do usually. And it again shows very nicely that immunotherapy basically used in the adjuvant setting usually does much poorer than immunotherapy which you use in a neoadjuvant setting. So probably, you know, having the whole tumor in place and all the trained lymphocytes and stimulate this environment before the surgeon takes the knife is a good concept. And if you first do surgery and eliminate the tumor, eliminate the antigens, and eliminate the lymphocytes which have found the tumor already, and then you do adjuvant immunotherapy, the results are much poorer. And this somehow aligns also quite nicely with TKI. I showed you the 10-year results for dabrafenib, trametinib in an adjuvant setting. And the fascinating thing is, if you just look numerically, then the adjuvant TKI therapy in melanoma is better actually than the adjuvant immunotherapy. And probably because you do destroy the immune environment through surgery. Good, then we have seen Keynote 522, which is perioperative pembrolizumab. So this is again a perioperative setting. You do give pembrolizumab also before surgery. We have seen 5-year OS data and the benefit of around 5%, and that's clearly a standard in triple-negative breast cancer. Then NATALEE data were published. NATALEE is adding ribociclib to endocrine therapy in an adjuvant setting. We have seen results for invasive disease-free survival, which is a standard readout for adjuvant breast cancer therapy. And you see there's a difference of around 3%, 91 versus 88% IDFS after 3 years. So this is something which many people do consider a standard. The benefit is quite small. So I think if you do have elderly or unfit patients, I would still think whether this really is a standard in those patients. You know, survival after 10 years may not be an aim in an 85-year-old after this kind of cancer, for example. But when you just look at the data themselves, then there is a benefit. We do not have OS yet. We are waiting for OS. If overall survival is going to be completely negative in around, I guess, 3 years, then it may never turn into a full standard. If overall survival is going to be positive, this will definitely turn into a standard in oncology. Then we continue adjuvant pembrolizumab chemotherapy in endometrial cancer, the NGOT-N11 trial. Also an interesting trial, also using checkpoint inhibition, also in the adjuvant setting. It's a bit repetitive, isn't it? We look at 2 populations. One population is mismatch repair deficient, which is the top one, and we have mismatch repair proficient. And I think it's pretty clear. So for endometrial cancer, the mismatch repair deficient population needs to get the checkpoint inhibitor in the adjuvant setting, while there's no benefit in the mismatch repair proficient setting. So, you know, if you ask me, why is it that in one entity we need to have microsatellite instability to see the benefit, like colorectal cancer, like endometrial cancer, and in other entities, immunotherapy, melanoma, you don't need to have mismatch repair deficiency or anything, and it's working very nicely. I think that's still something which is up for debate, and we don't really understand the biology behind this so far. And the example is the next trial, actually, Keynote A18, which is, again, more of the same, peri-interventional, so not just adjuvant, but now before and after surgery, pembrolizumab in locally advanced cervical cancer, together with chemotherapy, so the very standard, cisplatin. We do have radiotherapy, brachytherapy, and then you add the pembrolizumab to this very standard therapy. And what's the outcome? The primary endpoint was overall survival. We have seen publication of the interim analysis too, and the hazard ratio is 0.67. And now in cervical cancer, all of a sudden, there's no difference now between mismatch repair deficient and mismatch repair proficient. So for those patients, this is a standard irrespective of the mismatch repair deficiency status. Then we move back to uro-oncology, renal cell cancer, 2024 publication of the overall survival data of Keynote 564, adjuvant pembrolizumab. Hazard ratio is 0.62. So there is a benefit. It's not a huge benefit. It's a limited benefit, but it's a measurable benefit. So the difficult question in this study is there have been other studies using checkpoint inhibitors in renal cell cancer in the adjuvant setting where we have not seen a benefit. This trial has shown a benefit. I think the trial is straightforward. This is a standard, but please explain to me why one trial is positive and the other one is not. So how to deal with this kind of trial heterogeneity is still a challenge in oncology, obviously. Then we move to bladder cancer, and that's a very nice example where we have 2024, two trials more or less back to back, one using the adjuvant approach and the other one using the perioperative approach, so neoadjuvant and adjuvant. Adjuvant pembrolizumab hazard ratio is basically 1, so that's not a standard. Don't use adjuvant pembrolizumab in muscle invasive bladder cancer after surgery. But if you look at perioperative durvalumab, again given before surgery and after surgery, all of a sudden there's an OS hazard ratio of 0.75, and I believe, Anya, this is a standard, probably, okay? So it's some kind of saying yes without too much enthusiasm. Okay, good. Okay, so I think from data it's clear this is a possible standard. It's not a huge difference, but it is there. And if you want to give it, you need to give it in a neoadjuvant way, not just the adjuvant way, because otherwise there's no effect whatsoever. Then we move into a somewhat rarer population, which is soft tissue sarcoma. This was a Stand Up to Cancer initiative, SARC 032, and they used, I believe it was 1 year of pembrolizumab, again 3 cycles of pembrolizumab in the neoadjuvant setting and 14 cycles in the adjuvant one. So all in all, it's around 1 year of pembrolizumab. What you can see, disease-free survival in the modified ITT population was 0.61, but there's no difference in overall survival. So again, this is a bit kind of a debate. I think it's not full standard since we have not seen an OS benefit. But anyway, the group really needs to be commended. It's a difficult trial, and it's good that we do see this kind of trial also in sarcoma, because we've not seen so many sarcoma trials for many, many years. Okay, now we're moving to the palliative part, okay? And yeah, it's a bit more. Let's start with Godzilla trial. I mean, when you see Godzilla, you know what country performed the trial, okay? Just form a name in your brain. And yes, it was Japan, obviously. They have run Godzilla trials, so they have looked at ctDNA analysis seriously in gastrointestinal cancers. What they have not done, and that's really a shortcoming of this trial, they have not compared this to standard NGS of solid tissue. So basically, we don't know what the difference is between assessing the solid tissue and doing the liquid sample. But if you do the liquid sample and there is a target which you can match to, and you do treat the patient according to the matched target, then you will see that OS is going to be a little bit better than if you do not match. So I don't think that's very convincing. But the interesting stuff is the next two analyses, because when you do look at liquid samples, the very good thing is you do get a quantitative analysis. So you can, for example, ask about clonality. You can ask, as they did in this trial, if the matching target, the target you match your therapy to, is this highly clonal, so almost all the tumor cells do have this target, compared to a situation where very few tumor cells do have or express the target. What is the difference? And the interesting thing is they can show a difference in progression-free survival. Again, it's not, I mean, hazard ratio is nice, but this is because overall survival is short, so it's not as impressive as it might be. But we do see a tangible PFS benefit compared in those patients with high clonality compared to those patients with low clonality. And that's really the first time we can introduce the concept of clonality into decision making, because using this liquid approach, you can assess clonality for every single target you look at. And that's just how they do the math, which is quite simple. They look at the maximal variant allele frequency detected in this sample, and then they take the target and they do a simple division. So I think that's really interesting. And this may also be a benefit actually of liquid sampling, because we are not able to do the same in solid sampling. Of course, we could also do the variant allele frequency, and we do the variant allele frequency of the solid metastasis, but this is just, it's one needle, while in the liquid compartment, it may represent all different sorts of metastasis. And they did exactly the same or a very similar analysis looking at the copy number of the markers, so not just clonality, but they also looked at the copy numbers, and they see the same. So the higher the copy number, the better the PFS. So I think that's quite interesting. Let's move on to more basic oncology stuff. We have seen the overall survival data in the palliative setting for gastric cancer with zolbetuximab in Claudin 18 positive cancers for Spotlight and Glow. So these were two trials, and they published the OS results as a brief report in the New England Journal of Medicine. The hazard ratio was 0.77, and it's a gain of a bit more than 3 months. So that's basically the first OS data for a Claudin 18 directed therapy. And we're going to have approval for first line, but we do also use it in further line. Then we have seen the overall survival for Keynote 811, which is HER2 amplified gastric cancer, and the OS hazard ratio was a little bit below 0.8. So for those patients who have got a HER2 positive and PD-L1 positive gastric cancer, the new standard is to combine anti-HER2 and PD-L1 therapy together with chemotherapy. That's also data we have seen 2024. Then that's something we've been discussing for, I feel like 15 years, whether you should do surgery on primary colorectal cancer. So is there any benefit of removing the primary colorectal tumor in a palliative situation? And there have been two large German trials, which is Synchronous and CCRE4 trial. They have done a joint analysis of both trials together, looking at the overall survival, and just looking at the very simple question whether primary tumor resection was done or was not done in a randomized fashion? And the answer is very clear. And that's also one of the red stuff, okay? Never do it again in your life. No surgery of primary colorectal cancers in a palliative setting. There's no benefit whatsoever. And, you know, it's been a long discussion, but data is very clear. We should not do surgery on those patients. I mean, obviously, if you do it for a palliative intent because there's stenosis, that's a completely different story. And you're welcome to continue and do this, but don't do it with an intent of improving prognosis. Then also Nature Medicine 2024, we have seen the publication of the hyperselection data. So what happens if you look at colorectal cancer, and then you don't just say, oh, well, since it's right, I do this therapy, or since it's left, I do this therapy, but you look at a series of markers. That's what is called hyperselection. So you select for KRAS, NRAS, PTEN, EGFR extracellular mutations, HER2, MET amplifications, ALK-RET, and NTRK1. They have published this last year, and they showed that using hyperselection as a marker to decide whether you should give anti-EGFR antibodies or anti-VEGF antibodies gives you quite a nice result. So you see a difference of 6 months OS if you make the right decision based on this hyperselection. Now, obviously, you know, what we've all learned is right and left, okay? And the question is this better than right and left? And nobody has done a trial looking into right and left versus hyperselection, but you can just do the intertrial comparison. As always, blame on me if I do intertrial comparisons, but it's the only thing I can show you. And if you look at right versus left, without hyperselection, you have a difference of 4 months. So usually people would say, use the factor which is more discriminative of one situation versus the other one, versus which in this situation would be hyperselection. I'm not sure we will ever see a randomized trial answering this question. So if you're asked in an exam for oncologists, you should always say, we don't know, okay, that's the correct answer. But if you do inter-trial comparison, then hyperselection works better than left and right. Okay, well, that was a nice curve. That's PFS with ipilimumab and nivolumab in mismatch repair deficient colorectal cancer, now in the palliative setting, okay? So I showed you niche, which was in the curative setting. Now we are in the palliative setting, looking at patients with MSI, microsatellite unstable metastatic colorectal cancer. And the question whether you should give chemotherapy or nivolumab and ipilimumab. So first, obviously the trial design is kind of, you know, bit old, because in the meantime, checkpoint inhibitor monotherapy has already become the standard for this category of patients. But when you now look at this comparison to chemotherapy, you see very nicely, PFS, progression-free survival at 2 years, is 72 versus 14%. So it's again a very impressive kind of divergence of PFS curves. And we already, you know, somehow like to do ipi-nivo in pMMR mCRCs, in mismatch repair deficient colorectal cancers in the palliative setting. And now we finally have the data showing this huge difference in PFS. And the PFS difference was so huge that Swissmedic just a few days ago decided to approve this as a therapy. So ipi-nivo is now an on-label therapy for patients with microsatellite unstable metastatic colorectal cancer. So I think for young and fit patients, that's the absolute standard. Perhaps if you have very elderly, you know, beyond 80 years, you might still think of using anti-PD-1 monotherapy in those patients. And then that's something we've also been waiting for many years. You know, in colorectal cancer again, there can be Pol Epsilon, Pol D1 mutations. And these mutations typically, you eliminate the proofreading domain of the polymerase. And if you eliminate the proofreading domain, then you get all sorts of mutations, and you get more mutations than with microsatellite instability. So the median for colorectal cancer microsatellite instability is around 2,000 mutations. The median for Pol epsilon or D1 mutant metastatic colorectal cancer is around 6,000 mutations. Okay, so it triples the number of mutations. It's very rare in colorectal cancer. We have started to use anti-PD-1 antibodies in analogy, but nobody knew whether this would really do the job. And that's actually the first trial. It's just a phase 2 trial. It's a small trial published in Annals of Oncology 2024, looking at PFS, hazard ratio and OS hazard ratio. And what they compare is not the therapy itself. So they just look at checkpoint inhibition therapy, be it PD-1 or CTLA-4, the combination, but they look at the prognosis of those patients with microsatellite instability, which is the red curve, and those with Pol epsilon and D1 mutations, which is the blue curve. And you can see that PFS and OS is better in those patients with Pol epsilon mutation compared to MSI. And when you see the excellent prognosis of MSI high patients with checkpoint inhibition in colorectal cancer, then I think there's no doubt that this is a standard for those patients with Pol epsilon and D1 mutations. Although, obviously, with 27 patients, we are still far away from any approval for this kind of therapy. Okay, 85 slides, so I need to be careful a little bit. Liver transplant. So a very interesting trial published in Lancet 2024. If you cannot get rid by liver metastasis of colorectal cancer by doing surgery, you could get rid by doing liver transplant. Okay. Yeah, well, I think it's true. If you can do liver transplant and you look at the overall survival curves, you see a benefit for those patients undergoing liver transplant. This is a nice trial. It's a small trial, 47 patients in each arm. So basically it is an interesting trial. The problem is, in my view, another one, which is this. I'm not going to read this to you, but this is the inclusion criteria for this trial. Okay, so basically for the next 10 years, you're not going to see a patient who fulfills those inclusion criteria. If you have the super fit patient who really fulfills all of those, good liver function and no other diseases, and this whole list, you can think of this, okay? Would I consider this a standard? I can't. I mean, look at this inclusion list. You will always find a very specific situation where a therapy can be beneficial, but you can never, expand this into the overall population. No way to do this, okay? Based on inclusion criteria, and no way to do this based on the availability of transplant. So it is a possibility for very, very selected patients, but it's certainly not the general way now to tell all our patients, oh, we're going to do a liver transplant for you, colorectal cancer. Then anal cancer, so we move to the bottom slowly. Podium, which was combining carboplatin and paclitaxel to retifanlimab, which is one of the many, many PD-1 inhibitors. And you see overall survival was 0.7. This was not the primary endpoint. And you have a median overall survival of 29 versus 23 months. It's a small trial. There's a very significant benefit in progression-free survival. There's a nice trend in overall survival. I don't know whether we're going to see either a larger trial or perhaps we will see OS benefit with longer follow-up. But I think from the data we see this is a standard. It all makes sense. It's a tumor where we do see response to PD-1 inhibition also in second line or third line setting. We just move it into the first line setting. We do have a proven PFS benefit and a numerical difference in OS. So I think that's ready for everyday use. Then we have seen NETO2, Lancet 2024, lutetium dotatate first line in NET-G2 and NET-G3. When you look at the PFS hazard ratio 0.28, so it's quite a nice benefit. We don't have overall survival data for this trial. I mean, you know, basically the question for first line NETs, the well-differentiated NETs obviously is, do we need to do anything or can we just wait? If we can't just wait, do we need to give somatostatin analogs, which would be the usual way to go so far? Or do we need to do radiopeptide receptor therapy as a first line? And for the last 10 to 15 years, we've always said, if there's quite some tumor load and some relevant dynamics, then you should go into PRT in the lutetium dotatate or dotatate therapy in first line. If there is not a lot of tumor and there's slow dynamics, then you can just start with the somatostatin antagonist. And I think this is still true. So we have got more data. It's not really changing the standard because it's mostly what we already did. And it's still nice to see that what we did so far is not completely wrong. Then for neuroendocrine tumors, we've also seen cabozantinib. Second and further line in neuroendocrine tumors beyond sunitinib, for example, or everolimus. There were two cohorts. One is extrapancreatic and the other is pancreatic. And you see, we see a benefit in progression-free survival. We do not really see a benefit in overall survival. The trial was not geared towards overall survival. And it's more or less the same for the pancreatic NET cohort. So it's interesting data. It's not a large trial. It's a rather small trial. I think it is an option for certain patients, not necessarily for everybody. Then we have another trial which was definitely practice changing, Adriatic for small cell cancer limited disease. So looking at the addition of maintenance with durvalumab or durvalumab tremelimumab. The combination cohort has not been reported as far as I know, but we have seen the reports of the durvalumab cohort. And for small cell lung cancer, limited disease, that's really the first trial in 30 or 40 years showing any benefit in overall survival. So it was still platinum and etoposide, and now we move to platinum etoposide and a maintenance with durvalumab. Again, to understand the mechanisms is not easy because there have been trials negative for the combination of checkpoint inhibition with platinum etoposide if you give it in a concomitant way. And the only trial which has now proven to be positive was the one not giving it at the same time of chemoradiotherapy, but giving it afterwards as a maintenance therapy. I mean, this is definitely a standard. I'm just saying I don't know exactly what the mechanism is, why we should only give the checkpoint inhibition after chemoradiotherapy. Then we have seen publication of the first line data amivantamab lazertinib. You know, amivantamab is a dual or bispecific antibody against EGFR and MET. So in a way, you do also tackle one and the most frequent resistance mechanism in NSCLC, which is MET amplification or some other mechanism of MET activation. You see there's no significance difference in terms of overall survival. When you look at progression-free survival, there is a difference. So I guess this is one of the examples where it is not yet a standard for first line because we don't see overall survival benefit yet. So I think we want to see the overall survival benefit before we declare it a standard. Also because osimertinib is quite well tolerated and we do have more side effects with this combination. If there is going to be an OS benefit, this will be the new standard, but it will take at least perhaps 2 more years to see whether this is the case. The difference, or it is different for amivantamab chemotherapy after osimertinib, because after osimertinib, the first-line therapy for EGFR-activated NSCLC, we don't have any approved therapy and any positive phase 3 trials so far. Now we have seen results of Mariposa 2, and this quite relevant PFS hazard ratio benefit, 0.48. And this again has been approved by Swissmedic and by the Swiss Federal Office of Public Health. So it's in label, it's reimbursed. When you have patients moving out of standard first-line TKI therapy in EGFR mutant NSCLC, then this is the new standard second-line option for those patients. Okay, so that was an impressive trial for ALK-rearranged non-small cell lung cancer. First line, lorlatinib versus crizotinib. So you have a further generation ALK inhibitor versus the first generation one, which is crizotinib. We don't have OS data because OS is not really mature yet. And after 60 months, after 5 years, the median progression-free survival is not achieved. That's not bad. So just for information, I put the median PFS of some other agents, some other targeted agents. So for example, enzalutamide prostate 50 months, or we have alectinib 26 months, avapritinib Bengist is 34 months. So more than 60 months is the only TKI so far which has shown more than 60 months PFS. We'll see. It's going to be, I don't know, 70 months though. Anyway, so, I mean, again, that's very relevant, this prolongation of PFS. We're going to see OS data later on when more events have happened, but I think it's a very good option to use this kind of therapy in those patients. Then we do have more inhibitors, okay? So there's so many new TKIs, it's very difficult to understand what is happening. That's repotrectinib for ROS-fused NSCLC. And for ROS-fused NSCLC, we have usually used also crizotinib, so an old inhibitor. And this is the first kind of dedicated inhibitor we see in TKI naive population and in TKI pretreated populations. Quite nice response rates. So I think we're also going to move to new ROS1 inhibitors in the first line. And I think, Lorenz, you've used this already? Or yeah, good. So we are using this already. And obviously, we want to have more data on this, but the waterfall plot already looks quite impressive. Then we've had 2 or 3 years ago, I'm not sure actually, Anja, perhaps you know. So the first approval of belzutifan was 2 or 3 years ago, more or less, in neuroendocrine MEN mutant HIF alpha upregulated cancers. For those diseases, it works quite nicely. We have now seen data for renal cell cancer. That's a bit more sobering. So there's not really a huge difference if you use belzutifan versus everolimus after immune checkpoint and VEGFR TKI. There's a bit a benefit. I mean, there's at least a tendency numerically better OS. I do not really have experience on the side effect profile. I guess you do have the occasional patient on this therapy already, Anja. So the feeling in the end is this drug needs to have a companion somehow, okay? It's probably not going to be effective enough on its own. It's a very interesting mechanism. It's fascinating. We can target these transcriptional factors, HIF, so that's very good. But it doesn't seem to be enough for this population. Then we've seen publication of EVP, enfortumab vedotin and pembrolizumab, which has already been introduced in the clinic. We have seen presentation at some meetings already 1 year before that. OS hazard ratio 0.47, median OS 32 versus 16 months. So very clearly the standard in bladder cancer, and we also do have quite a series of patients already on this drug combination. There is some toxicity, so we've seen some hemorrhagic cystitis and this kind of stuff. It's always the question, you know, is this immune therapy related? Is this the ADC, the drug conjugate? I think it's not very clear yet. Interesting therapy, but still some improvements on the level of side effect management needed. Okay, so you have 14 more minutes, okay, and then we are done. And, you know, so as a little break and motivation in between, there's going to be an apéro outside. And I've been told by Silke, I really have to tell you about the apéro, because last time everybody stepped out and people forgot about the apéro. So the people serving the apéro were very frustrated. So today, please take it seriously and go over and grab some food afterwards. So let's move on. We have seen a trial on lutetium PSMA versus change of androgen deprivation therapy. This was the PSMA-4 trial. You can see in terms of overall survival that there's no benefit whatsoever. There's a difference in PFS, which I feel somehow is not really a surprise. I mean, changing the RP is perhaps not the best strategy in this situation. However, what I think is, at least for me, somewhat convincing is the quality of life data. So we do see an improvement in quality of life using the radiopeptide ligand therapy. So I guess this is also an option, a standard which should be offered to our patients, mainly because, as I said, you do also see some improvement in quality of life, although there's no clear overall survival benefit in this population. Let's move to breast cancer, and I mean, endocrine therapy in breast cancer is very old, so it's quite impressive. We do get new endocrine therapies, and then they're doing something. So imlunestrant is a new oral selective estrogen receptor degrader, and it has been tested in EMBER-3, which is kind of quite a complex study. So they looked at the endocrine therapy in lumestrant on its own, then on standard of care fulvestrant exemestane, and then in lumestrant and abemaciclib. And there was a primary endpoint also in this red group down there. So let's first look at the effect of imlunestrant on overall survival, stratified according to ESR1 mutations, so presence or no presence. So here we have the full population, here we have only the population of ESR1 mutant cancers. So you know, ESR1 is thought to confer resistance to endocrine therapy in breast cancer, and it's not the first drug which is used to kind of circumvent this resistance. And what you can see here is that the benefit in terms of OS seems to be more relevant for the ESR1 mutant group, but interestingly enough, also if you look in the full population, you do see some differences. So obviously, gradually, step by step, we still get better endocrine therapies. It's not a big difference, it's a small difference, but there is still a difference. Then there was the comparison with and without abemaciclib with an endpoint of progression-free survival, not overall survival, and there was a clear benefit, and that's also a primary endpoint of this trial. So both in CDK pre-treated and CDK naive patients with breast cancer, imlunestrant and abemaciclib did pretty well. Okay, so more options in breast cancer, interesting, and we're still gaining time for women with estrogen and progesterone receptor positive metastatic breast cancer. Then, also in breast cancer, we've seen the combination of palbociclib, fulvestrant, and inavolisib, a PIK3CA mutant. That's the old trick. You give it in further line, and then when it works, you take it into an early line and combine it to other drugs, and that's exactly the same which has been done in this trial. If you have, for example, PIK3CA drugs approved also in the further line therapy, then obviously PFS is not enough, because you can give it first line, you can give it second line, you will see a PFS benefit. But if you want to bring it as a combination therapy, increase toxicity into first line, then usually you need to see an OS benefit to make it a standard therapy. And that's what you can see here. I mean, it's not significant, but it's numerically a benefit of 6%, which is not bad, again, in this situation for a triple therapy. Then, continuing with breast cancer, sacituzumab govitecan, triple negative breast cancer. What we have seen is now the publication of the OS results for the quartiles of the expression of the receptor. So they looked at TROP2, then there are 4 quartiles of TROP2 expression on triple negative breast cancer samples. And when you match this to overall survival of patients, you can see there's a benefit for all quartiles, also for those with the lowest expression of TROP2, but obviously the difference is bigger if you have a higher TROP2 expression. So again, that's a standard, and for the first time we have clarified now the question whether you need to do this TROP2 assessment. You basically don't have to do it because you do see benefit in all groups. Then trastuzumab deruxtecan is also a drug which has kept us busy in trials the last few years. It's been approved in a tumor agnostic way. So all tumors with HER2 overexpression can be treated by trastuzumab deruxtecan. I'm going to show you, I believe it's 3 or 4 trials with more data on trastuzumab deruxtecan. First one is using this compound compared to trastuzumab emtansine in second and third line HER2 positive breast cancer, and we do see an overall survival benefit with an absolute increase of median overall survival by around 10 months. Okay, so that's a standard. Then there's some data on trastuzumab deruxtecan in breast cancer and brain mets with a 1-year PFS of CNS metastasis of around 60%. Which is also quite interesting. So it's an option for breast cancer patients with intracranial metastases. So this is stuff I feel, we've seen some way or not already. That's pretty new, and I think that's also interesting because now you look at trastuzumab deruxtecan versus chemotherapy as first line after endocrine therapy in HER2 low. Okay, so a very specific population, breast cancer patients, HER2 low, they have exhausted endocrine therapy, and now you give either whatever physician's choice chemotherapy or you give trastuzumab deruxtecan, and you do see a PFS benefit, which is quite important, of 0.62. So again, no OS data. The books are not closed on this issue, but it's quite impressive, and I think many people will move towards this kind of therapy for this specific patient population. Okay, that's the basket I mentioned already. We have got tumor agnostic approval, which is fine enough. So this is one of the trials. I don't really know what to do with that one. So niraparib is a PARP inhibitor. And usually we think PARP inhibitors are very efficient in homologous repair deficient cancers. And one of the diseases which is the most homologous repair deficient is ovarian cancer. And now we have this trial with niraparib, and in homologous repair deficient ovarian cancer, we don't see an overall survival benefit. So please don't ask me what it means. I think this will need some workup. That's not expected. I mean, we've seen some hints at problems with niraparib in this population already, so that's not coming completely out of the blue, but it's still somehow difficult to understand why the benefit should be gone. I mean, you know, you can give it later on in later lines, and you can rescue the phenotype with another PARP inhibitor, whatever. I mean, there are many possible explanations, but I think we need to look deeper into this to understand why we do not see an OS benefit in this population. Then cervical cancer, tisotumab vedotin, also standard, also a new standard. So that's a new antibody drug conjugate, anti-tissue factor plus chemotherapy, and we have an overall survival benefit of 0.7. So that's clearly a new standard in further line cervical cancer. P value is 0.004. So I think that's a good further line standard in this patient population. I've never used this compound so far. Anybody who've used it already? Any experience with it? Just raise your hand or shout. No. Okay. No. Yeah, but you could import it from abroad. But I've never seen anybody with this compound. So, well, data's there, and clinically we can consider it a standard. Let's see whether we get approval and access to this kind of compound. Then also New England Journal of Medicine 2024, Ipi/Nivo 10-year OS data, checkmate 067. It's not so much news. It just shows what we have seen the last 10 years. You do have a benefit with the combination therapy. It's not huge. It's around 6% after 10 years. And obviously the nice thing would be, you know, to know who needs this, because toxicity is very relevant. So if you add ipilimumab, and if we knew who needs just the PD-1 blockade and who needs the combined blockade, this would be a major step forward. But we don't. Okay, so it's still very difficult to make decisions for those patients. Then there was another trial in sarcoma, which was very interesting, and this was also an academic trial, so very well done by this group. It's a French trial looking at doxorubicin and trabectedin plus trabectedin maintenance versus doxorubicin. So we always said in sarcoma, combination therapy has not really a space, you know. I mean, you can give it if you want to have response, but it doesn't do anything in terms of OS. And that's the first trial which proves for this combination, at least it's wrong. For this population, doxorubicin trabectedin combination gives you a better OS than the doxorubicin monotherapy. So that's really an achievement, and we've not seen anything like this for many, many years in sarcoma. Okay, there's some more. Vimseltinib, which is an oral CSF1 inhibitor used in tenosynovial giant cell tumors. There's a phase 3 trial. There's just a waterfall plot. The disease has a very good prognosis, so we will probably never see OS curves for this disease, but it's working very nicely, and I just wanted to make you aware there's a new compound which may be used for this class of cancers. Then IgG4-related disease. Who has treated the IgG4-related disease last year? Nobody? Yeah. Well, the funny thing is, many years ago, I had a lymphoma patient, and I treated this lymphoma patient, not in this place. After 2 years of complete remission, he all of a sudden had new nodules in his kidney. And we all thought, well, that's the lymphoma coming back. And then we actually did, you know, needle biopsy. But what we found was an IgG4-related disease. So this was not a lymphoma relapse. IgG4-related disease, that's tumors. You know, you can think it's a metastatic disease, but it's not. The standard therapy so far was steroids. You know, you give steroids, and then these tumors wane, and when they come back, you give again steroids. And now we have the first trial using an anti-CD19 antibody for IgG4-related disease, and you see the probability of no flare is much higher when you use this kind of compound. Okay, Cupisco trial, which was run also in Zurich, and we have the head pathologist of Cupisco with us. So that's very nice, and it's very good to see this trial published. You do see some PFS benefit, mostly for the molecular targeted therapy, not so much for the atezolizumab chemotherapy combination. I think it's a nice proof of concept. I mean, of course, it's not always, and it's not, you know, proving a very high value of all of these therapies, but it's the first time we've seen a very well-controlled trial, very well run, that we do have a benefit, at least in terms of PFS for very specific targeted therapies. And we get to the last slide. I see I'm going to be 1 minute late, sorry for that. And that's also very interesting because it's the first compound against cachexia. So we've never seen anything which does anything in this kind of you know, side effect of the tumor. And for the first time with anti-GDF15 antibodies, we do have now a treatment for cancer-related cachexia, and we have a change in weight from the baseline, so patients for the first time really gain weight. What is still missing is what does this mean for overall survival? What is still missing is what does this mean for quality of life? So we will need to have more data, but it's the first time ever we see an improvement in cachexia itself. And if it is true that 1/3 of our patients die from cachexia, not from the tumor, then we should see also something at the level of OS in the next few years. Okay, so thanks a lot for you know, staying here until the end. And just remember, there's going to be an apéro, and if there are questions, just let me know.